We're still talking about the characteristics of the cardiovascular system, namely the tubes and how they conduct and how they respond. One of the things you have to remember about our cardiovascular system is that we can use physics properties of pipes and tubes, but that's a bit of a simplification for our physiologic purposes because our tubes can change, right? The pipes in the wall that bring water into the bathroom, they don't change size and they don't have any capacity to do that. Well, our system is more variable than that. So we have to talk about some of the more advanced characteristics of the tubes in our system. So we have these two ideas, distensibility and compliance. Okay, so distensibility describes how easy it is to increase the volume of a particular vessel. All right, so if we look at a vessel, if a 1 millimeter of mercury pressure change causes an increase in volume of +1 in a 10 milliliter vessel, then we would describe the distensibility as 10% per millimeter of mercury. In other words, that vessel gets 10% bigger for every 1 millimeter of mercury pressure increase. Okay, so what we're describing here is how easy is it to make that vessel bigger? How much pressure does it take to make that vessel bigger? And our different pipes are not equivalent in this characteristic. So veins are 8 times more distensible than arteries. This is part of why they contain that 2/3 of the blood at any given time, because they're so distensible. So for the same pressure increase, veins will get 8 times bigger than arteries will. All right, so that's one key difference. Another is between the pulmonary and systemic arteries. The pulmonary arteries are much more distensible than the systemic arteries are. But the pressure in the pulmonary system is also about 1/6 that of the systemic system, which means if you're doing the physics math there, it's kind of a wash, right? These vessels are about the same size, even though the pressure that they contain is 6 times different, right? So it means that the pressure to make the same distension in the pulmonary veins, or arteries rather, is significantly less than in the systemic. That makes sense because we have much less pressure around, right? But it also means that in a disease state like pulmonary hypertension, where the pulmonary pressure is significantly elevated, it means that the pulmonary arteries get quite large, right? They distend quite a bit because they are much more distensible than the systemic arteries are, okay? So that's distensibility. Distensibility is increase in volume over the increase in pressure times the original volume, all right? Now, it's kind of a similarly described idea, and frankly, one that's used much more often, all right, is vascular compliance. I think compliance is easier to understand than distensibility. They both kind of describe the same thing, which is how easily does a vessel stretch out, right? So compliance is a word we're going to use to talk about a number of things in this class, including the lungs. So just to give you an example of a different look at compliance, okay, we've all encountered a water balloon, right, and an air balloon. Okay, which is easier to blow up? The air balloon, right? That means that the air balloon is much more compliant than the water balloon is. In other words, to get the water balloon to increase, we have to put a lot of pressure in to get a small volume change, right? Compare that to a regular balloon that, say, you've blown up a few times, right? You only have to put a small amount of pressure in to get a quite large volume change. Okay, so that is compliance. It's the total increase in volume for a given increase in pressure. It can be a little, yes, less useful than distensibility because compliance is going to vary by vessel. In other words, each vessel has a compliance, where distensibility we can use to talk about the whole system. And you can relate the two. So compliance is distensibility times volume. And I'll tell you, this is the one I'm going to use, okay? Compliance, because it's a little more applicable to a little more things. So like the systemic veins are 24 times as compliant as the arteries are. So where do we get that? They're 8 times more distensible, we talked about that already, and they have 3 times the volume. So we multiply those together and we get 24 times. So compliance is increase in volume per increase in pressure. And that's not just vascular compliance, that's compliance period. It's always the change in volume over the change in pressure, all right? So that's compliance, and we'll use that term a few more times. Okay, so our pipes are are living cells, and living cells, of course, respond to change. So it means that when we add volume to the cardiovascular system or take volume away, the cardiovascular system itself responds to that change, all right, because these are living cells. So we have a few changes that happen. Number one is elasticity. If you look at smooth muscle in arteries and veins, they are a bit stretchy. If you put pressure in, it dilates a little. When you take pressure away, that dilation kind of snaps back, again, like a balloon, right? So that's one characteristic. Another is, and this is where we're different than a balloon, our vessels can get bigger, right? Because the smooth muscle can relax and actually increase the diameter. Now there's a thing a balloon can't do, right? It can't relax and get bigger, but our vessels can. So it means that we get this pattern of delayed compliance. All right, so let's look at our chart here. This is time. This is pressure. Okay, so we have a patient who's, we'll call this their right atrial pressure is at about 5, okay? And now we're about to do a thing that we do to patients very, very often, which is we're going to give them a bolus of fluids, right? So we're going to give them 20 cc's per kilo of normal saline. Well, what will happen? Well, if we push that in, we are going to get an increase in volume, right? So we're going to add our liter of normal saline. The first response that we'll see is an increase in pressure. Why? Because we've taken a new amount of volume and we've kind of squeezed it in to the existing cardiovascular system. So the first response we'll see is an increase in volume. All right, well, the body is going to respond to that increase in volume in 2 ways. Number one, the vessels are going to stretch out a bit. That's elasticity. Number two, the smooth muscle in the walls is going to relax. So we're going to have vessels that get bigger. In other words, the vessels are going to grow larger to accommodate the additional volume. So while we do get an increase in pressure initially, that increase in pressure starts to fall off. Now, it doesn't go all the way back down to where we started, right? But the big pressure increase we get from adding volume does reduce as we wait a while, okay? That's delayed compliance. Elasticity and smooth muscle relaxation is causing an accommodation of this additional volume. Now, the same thing happens when we take blood away, all right? So now we've sent him to the blood bank and we've taken a unit of packed cells off of him, okay? Well, the decrease in volume will result in a decrease in pressure, a big one at first, but then as the smooth muscle now contracts and the elastic fibers kind of snap back, we'll have a slow increase in pressure that we also call delayed compliance. All right, this is a characteristic of the fact that our tubes are not dumb tubes. They will respond to challenges. If we add more volume, they dilate a little. If we take volume away, they contract a little, right? So we see this characteristic of delayed compliance. And here again, you'll probably see that I skipped at least one thing already. So just make a note. Pulse pressure. Okay, so you are going to be, in not very many months, checking pulses on your peers, and there's a whole long list of pulses that we feel at different pulse points. Well, what you're feeling with your fingertips on your radial artery, let's say, is what we call the pulse pressure. In other words, every time the heart contracts, it adds a little bit of pressure to the cardiovascular system as a kind of pushing force. We feel that pushing force push up on our fingers. Well, as we move from heart more distally in the cardiovascular system, we get what's called dampening of the pulse pressure. In other words, if we looked at the proximal aorta, the pulse pressure is very brisk and sort of rigid. We have a strong up and a strong down. By the time we get to the radial artery, that strong up and strong down has been squished a little. So it's a little less strong up and a little less strong down. We call that a dampening effect. So radial artery versus proximal aorta, we see the amplitude, in other words, the size of the pulse is smaller, and the distance between the top and the bottom is smaller all the way across. So what accounts for this dampening is the fact that our vessels have compliance. So it's actually related to the delayed compliance issue. So as we travel through different vessels, the resistance of blood flow, the resistance to blood flow that's imparted by the vessels, it kind of uses up some of the pressure that the heart created. You know, if you think blood has to pass through all these tubes, well, each millimeter it passes through takes up a little energy. So by the time you get to the end of a long tube, the pressure is lower than it was at the beginning. And that's what we see here in the dampening as we go from aorta all the way down to capillary. By the time we get to capillary, our pulse pressure has completely disappeared, right? Where did it go? Well, it got used up in resistance and compliance of stretching those vessels out. So the degree of dampening is proportional to resistance and compliance. Short version is this: the more distal in the cardiovascular system we are, the less of a pulse pressure will be maintained. So by the time we get to the capillaries, there isn't one. This is a good thing because the capillaries are very, very thin-walled. They can't withstand any pressure because their walls are literally thinner than a red blood cell are. So the fact that our vascular system takes up or dampens out this pulse pressure so that by the time we get to capillaries, we have a nice, smooth, regular flow of blood as opposed to a start and stop, right? So pulse pressure changes as we go from top to bottom. All right, this is the point where we get to talk about the theory behind taking a blood pressure, something that, you will all get very good at in the next year and a half. All right, so if we look up at the top, this is the chart we're going to be using to sort of describe this. What we have in red is our pulse pressure. This is pulse pressure at the brachial artery because that's where we usually check the blood pressure, all right? This is time, all right? And what this is our cuff pressure. All right, so we take a air-filled bladder and we wrap it around the patient's arm. And then we close this system and we inject air into this bladder. Okay, so what we're doing here is we're increasing the pressure around the upper arm. Okay? So at the top at point A, we have put a bunch of pressure into our cuff. So much pressure that the pressure around the upper arm is greater than our systolic pressure. Okay, we have created a tourniquet, right? That's what a tourniquet is. In other words, blood cannot flow past this area of high pressure because the pressure on the outside is greater than the pressure on the inside. So that's where we are here at A. Okay, so if we take our handy-dandy stethoscope and we listen over the antecubital fossa right there, all right, well, at A, we're not going to hear anything because no blood is moving because we've created a tourniquet, right? We've blocked that blood flow with pressure. Okay, so now we get into the exercise, right? We turn the little wheel up here and we slowly let air out of the bladder. Well, what's happening as we let air go out is the pressure of the cuff is decreasing. So we're removing pressure from around the upper arm. Well, at some point that pressure will fall below the systolic pressure. That's at point B. Okay, so at point B, the pressure of the cuff is equal to systolic blood pressure. And what we hear is kind of a tapping sound, all right, in our stethoscope. Because what we're hearing is there's just enough pressure that blood can zip through at the top of systole, all right? So B is our systolic number, right? So we're going to write that down as the systolic blood pressure. Okay, so now we continue to let air out of the cuff, okay, and our cuff pressure is going to decrease now from B to C. Well, as this happens, what we hear changes, because we're going from letting blood flow through just at the top of systole to letting more and more blood flow through. So between B and C, we hear kind of harsh sounds as the blood sort of jets by our impinged artery, right? So whoosh, 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 whoosh. Then at C, okay, where our cuff pressure equals diastolic pressure, we hear the sound change again because at point C, we're taking away the restriction of blood flow at that vessel, right? So the turbulence and the restriction that we put in place with the cuff, we're now taking away. So the sound changes first to kind of a muffled sound, and then when the resistance to arterial flow goes away completely, you go back to not hearing anything again, like we see at D, okay? So this system, surprisingly, I think, is actually quite accurate. It gives you plus or minus 10% compared to an invasive technique like putting an arterial line in and hooking it up to a computer, right? So given the risk and difficulty of that procedure, taking the blood pressure in this way is a remarkably good tool for assessing what the patient's blood pressure is. This just shows you a little bit about how that process that some of you have done hundreds of times actually works. Questions about that before we go on? Okay. Who knew all that before? Several of you, good. All right. All right, well, blood pressure changes with age. We start out and kids have a much lower blood pressure than adults do. Please don't ever forget that, okay? So like when you are working with children, you're going to have a list of normals per age, okay? Because all the vital signs vary in kids. So because children are smaller, they need less blood pressure. Their blood has less distance to go, okay? The other reason that kid blood pressure is less is their vessels are more compliant, okay? So children have wonderful collagen still, right? It's all nice and stretchy and all that. So the vessel compliance is much better, which means that the blood pressure can be lower. As we get older, our blood pressure tends to increase, okay? Now, this is beyond pathology, because you may also know that the older you are, the higher your risk for hypertension. Okay, it does absolutely relate to this. But even in someone who does not have hypertension, the blood pressure tends to increase as we get older because our vessels become more and more non-compliant. Even to the point that when you get into your late 80s and 90s, your vessels are kind of crunchy, for lack of a better term, because they're heavily calcified and very non-compliant. So blood pressure changes from young to old. The mean arterial pressure, okay, in other words, the average arterial pressure, you'll notice in my graph here, it's a lot closer to the diastolic number than the systolic number. Well, why is that if it's an average? Because if you look at the amount of time the heart is in systole versus the amount of time the heart is in diastole, you'll see that most of the time the heart is in diastole, right? 60% of the time the heart's in diastole. So that means that if you look at the average blood pressure, it's going to be closer to the diastolic than the systolic, right? So, and sometimes we do talk about MBP, mean blood pressure, or mean arterial blood pressure, and it's typically quite a bit closer to diastolic. Now, if we increase the heart rate dramatically, like if we increase it to 120, 150 beats per minute, this difference starts to go away. The faster the heart beats, the more time it spends in systole, right? So at like a heartbeat of 200, it's about half and half, so then our mean is in the middle. Just see how that works. But of course, people don't typically spend a lot of time with their heart rates that high, so we can effectively ignore that. Okay, right atrial pressure. The right atrial pressure is it should be the lowest measurable pressure in the cardiovascular system. Because, to use my roller coaster analogy from the other day, the right atrium is the station, right? We've got to get the roller coaster back to the station so we can put more people on it. That means that it needs to be the lowest pressure of the whole area. So like the pressure in the veins in your hands, for example, have to be a little higher than the pressure in your right atrium. Otherwise, blood's not going to flow from your hands back to the right atrium again. Okay, so right atrial pressure is the measure of the low end of venous pressure. In other words, what is the pressure that's pulling blood back to the heart? Okay. Now, what that pressure is at any given time is a balance between the amount of blood being pumped out of the heart and the tendency of blood flow to return to the heart. Now, over time, those are balanced, right? If you're not in heart failure, those are balanced, where the amount of blood going out is approximately the same as the amount of blood going in. At high heart rates, okay, so when the heart's working really hard, right atrial pressure tends to go down. This makes sense because the heart is pushing more blood out with more vigor, right? So the amount of blood that's waiting to be pushed gets smaller and smaller, the pressure gets less and less. On the flip side, high venous return increases right atrial pressure. So let's say we have venoconstriction, right? So your veins constrict. Where does that blood go first? Well, it's going to end up at the right atrium, right? Until the heart picks up its cardiac output and starts ejecting more blood, well, the right atrial pressure is going to increase until the heart speeds up and decreases it, okay? Now, how do we increase venous return? Well, one way is to increase blood volume. The example I gave earlier, if I give you a liter of normal saline, I'm going to increase your venous return because I've increased your plasma volume, right? I'm going to send more blood back to the heart because I've effectively increased the volume of your blood. So that's one approach, changes in plasma volume. We'll talk about plasma volume as the total amount of blood that is in the body circulating, okay? And this is a variable because every time you urinate, right, your blood volume goes down. And every time you drink, your blood volume goes up. So this is a thing that changes. Venoconstriction, that increases venous return, okay, as we were talking about. A decrease in total peripheral resistance. Okay, this one's a little harder to understand. If we make capillary beds all around the body more full, right, we'll end up with a decrease in the amount of blood returning. So if we decrease the total resistance, it's easier for the heart to push blood back or it's easier for the heart to push blood out and back. So we end up with more total blood flow, okay? Put a pin in that one because we're going to pick that one up when we go to talk about regulation, and that will make more sense, okay? Now, I do want to point out that venous return has a relationship with the Frank-Starling relationship. So the increasing venous return is essentially saying increasing the amount of blood that's returning to the heart. Well, I said the other day that when the heart gets more to do, it does that work better, right? Well, this is that connection. If I increase your venous return, let's say I give you a liter of normal saline, well, your heart is going to get a little stretched at end diastolic volume. That means it's going to contract a little more at end systolic volume, and it's going to effectively push out the extra blood that came back to it. See? So the Frank-Starling relationship helps the heart to balance venous return with cardiac output. Essentially, the Frank-Starling relationship says as venous return goes up, cardiac output goes up significantly, right? So it helps to keep us out of heart failure. So normally the right atrial pressure should be very close to 0. 1, 2, 3 is fine. 4, 5, 6, you're starting to get elevated right atrial pressure and the potential problems that come with that. All right, so the entire cardiovascular system is, of course, affected by gravity. So it means that we have another source of pressure. Our primary source of pressure is, of course, the squeezing of the ventricle, right? But the other source of pressure we have to deal with is what's called hydrostatic pressure. In other words, we are essentially a column of blood, right? And the blood is always being pulled down towards our feet, being pulled down towards dear old planet Earth. So if we measure the pressure in the cardiovascular system, we see the pressure is highest, venous pressure in particular. The venous pressure is highest in the legs, in the middle of the body, shortest or least at the neck. You know why? Because of the amount of blood that's just being pushed down by the planet, right? So we have, if we look in the head, we actually see we have a negative venous pressure. And that's because the head is this rigid container, right? It can't get smaller. So as the blood is pulled down towards our feet, we end up with a negative pressure in the sagittal sinus in our heads, to such an extent that blood is actually pulled up towards the head by this negative pressure. Another way to look at it is blood that travels through the brain is actually sucked into the sagittal sinuses as it passes through because of this negative pressure. So in order to overcome this pressure due to gravity, we kind of need another system to help blood get from the feet back up to the heart. And that other system is called the skeletal muscle pump. All right? And the way this system works, all of our veins have valves in them, one-way valves similar to what we have in the heart. We can see those valves, that's these guys right here, and this is really essentially what they look like. They're like a flap. So when blood pushes on the wide part of the flaps open. When blood tries to go backwards, it pushes the flaps closed, right? And blood cannot flow backwards. So it essentially means all of our veins have one-way valves in them. You can actually check on that in your wrist. If you play around, you can find the valves in the veins of your wrist. So the way we make this into a pump is we wrap skeletal muscle around these veins. So you've seen now in the anatomy lab some examples of that, of how a vein, for example, like around the deltoid, right? You've got a vein, and then right next to it is a muscle. Well, why? Every time that muscle contracts, it has a tendency to squish these veins. Well, when the veins get squished, the blood that's in them flows, and that flow can only be in one direction because of the valve, right? So when we squeeze on these veins from the outside by skeletal muscle, we create a pumping action that moves blood back towards the heart. It can be a significant amount too, like the skeletal muscle pump will move quite a lot of blood around back up to the heart, to such an extent that, like, if you are seated or lying down for a long period of time, several hours, for example, you will end up with dependent edema. You'll have swelling in your feet and ankles until you get up and move around, and that helps to mobilize and bring that fluid back up to the heart, and you'll see that your edema starts to go away. So we have the skeletal muscle pump, which helps to continue to move fluid back towards the heart. And then our last topic, and we'll hit the Kahoot tomorrow, is blood reservoirs. Okay, so at any given time, you've got only so much blood in your body. Well, your activity level can change. So some areas of the body work as kind of blood storage. It's not like a room. It's not like a closet where you put the blood in and close the door and forget about it, okay? The blood is still moving all the time, but it tends to move slower through these areas. So like the spleen has 100 milliliters, the liver has 200 to 300, large abdominal veins 300, you can read all those. All right, so the way we use these blood reservoirs is when we move from a period of rest to a period of exercise, the amount of blood in these places gets shrunk by venoconstriction. So we effectively reduce our storage and increase what we're actively using and sending through the capillary beds, right? So it's a way of increasing our circulating blood volume and our oxygen carrying capacity, all without having to create any new red blood cells in that, in the short term anyway. Okay? Yeah, I picked the adventure music today. So we were talking about vessel characteristics yesterday and how they work. So we got some questions about that. The degree to which a vessel changes its volume in response to changes in pressure. Yeah, that's vascular compliance. Another way we looked at this same idea is distensibility. Distensibility takes the volume of the vessel sort of out of the equation. I prefer compliance because it matches better with how we'll talk about the respiratory system. I thought maybe that was my batteries. Caitlin's going to bring down some batteries for the mic here in a little bit. So, yeah, change in volume related to change in pressure is compliance. All right, the prairie urchin. Never seen a prairie urchin. I imagine it would be a little dry. Okay, patient receives 2 liters of fluid, and the systolic blood pressure, that's SBP, increases by 20, but falls by 15 later. Why? All right, we got kind of a mixed delayed distensibility versus delayed compliance. We didn't really talk about delayed distensibility, okay? We talked about it as delayed compliance. And the way this works is because our cardiovascular system is all made of living cells that can respond, when we add fluid to the cardiovascular system, the initial response is a big increase in pressure. But that big increase in pressure drops off as the vessels dilate and enlarge, and as elasticity sort of absorbs some of that extra volume. So it means that first we have very little compliance. In other words, pressure goes way up, but then the compliance does occur. That's delayed compliance. So a reduction in blood pressure from the initial to the final compared to, so if we give a liter of fluid, we see a big increase and then it goes down. The same is true on the opposite end. If I take fluid out, same phenomena. Your pressure drops, but then it recovers a little bit. Thank you, Caitlin. Thanks. I just couldn't find any down here, so. All right. Oh, we got 2 urchins. We got a mystery urchin, too. Look at that. Okay. The sympathetic nervous system has which of the following effects? So I'm making you put some things together here. Yeah, so that's in all of these. Okay, so sympathetic nervous system has a number of important effects. One of those that we talked about briefly yesterday is mobilizing blood reservoir blood, right? So when the sympathetic nervous system is activated, it causes vasoconstriction, not only of the arteries, but of the venous system too. And that basically works to increase the amount of blood that can be present in the capillary beds, right? So increasing venous pressure and decreasing venous volume. Mobilizing blood from the venous reservoirs, and what's the one in yellow? Increases arterial pressure and decreases arterial volume. That's vasoconstriction, right? If we make the vessels smaller, we drive up their resistance, right? So the resistance to flow goes up. In other words, the blood pressure goes up. And we're going to tie that in with the hormonal controls of blood pressure after the exam. All right, 4 out of 5. When are vessel sounds first heard during a blood pressure measurement? Yeah, when the cuff pressure is approximately equal to systolic blood pressure. Now, to be honest, I would also have to give you the yellow one too, right? Because technically, when cuff pressure is just a hair less than systolic, you're going to hear blood flowing through because now it can, right? The whole way that we test blood pressure is we create pressure around the vessel with the cuff, we stop blood flow, and then we slowly release that pressure until blood flow starts again, right? So the measurement of blood pressure, definitely review that slide with the line across it. All right. Last one. Which of these helps blood return to the heart when standing? All right, so we talked about 2 of those yesterday, and I didn't talk about the third. Okay, skeletal muscle pump, absolutely. That's muscles contracting around veins because veins have valves that creates a pumping action, right? Low venous resistance, we did talk about that, how the veins have evolved to be low resistance pathways. The nice thing about low or zero resistance pathways is they don't require very much pressure difference to make blood flow, right? So because veins are large and very smooth-walled, it's very easy for blood to flow through veins. So we have low resistance and therefore greater flow. The one I just realized I didn't talk about was thoracic cavity suction. This is going to make more sense after the respiratory talk, but the way this works is this. Every time we take a breath in, we actually create a vacuum in our thorax. between the diaphragm and the ribs. That space that's defined by the ribs on the outside and the diaphragm at the bottom, right? Every time we take a breath, the pressure in that container goes down. And what happens is that has a tendency to slurp or suck blood up into the chest. So when we are breathing, which is all the time, right, we do have a periodic negative pressure in the chest that helps to pull blood back to the heart. It's one of the ways that we overcome the hydrostatic pressure, the gravity pressure, pulling blood down towards the feet all the time. And then one we talked about yesterday was in the skull, because the skull is a rigid container, the venous sinuses in the skull actually have a negative venous pressure. So blood is sort of pulled up towards the head a little bit too because of that. But all of those work together to help to return blood to the heart. All right, let's see who our winners are. The fast version. The Giving Impala. Very good. Nicely done.